Hi, my name is Brittany Toth, and I am a certified surgical technologist. Today, I want to talk to you about a craniotomy versus a craniectomy and kind of what our role is in that. Both of them being brain surgery, they both sound very familiar, but they are two very distinctly different cases. Both come with high stress. And so let's normalize it a little bit because remember, all surgery is the same, all of it. We have to get exposure, we have to stop bleeding, we have to take out or put back what does or doesn't belong there. And then we stabilize the patient and we close them up so that they can heal and be better off. So let's learn about a craniotomy and a craniectomy. So a little bit of what we're going to talk about, because remember in lab, we're going to do that hands-on piece. We're going to open our sets. We're going to set up our back table. We're going to set up the Mayo stand. We're going to get our hands on all those instruments that I'm going to briefly mention. I'm not going to go into huge detail with it. But we're going to go through all of that. So for this, I really want to just dig into what's the difference between the craniotomy and a craniectomy. Also, probably why is this patient having it done? Why are we here? Why are we getting called in at 2 a.m.? Or why is this on my schedule? What do we do? How do we survive? How do you kind of be like that duck on the water where they look like they're, cool as a cucumber and might be a little bit sweating on the inside? That's okay. Totally okay. Let's normalize it and kind of let's get through this. All right, so we're going to go back to medical terminology. So you have craniotomy and craniectomy. So how I like to think about it is like a craniotomy is we're making an incision into, right? We're not going to take anything away. We're just going to get into it. We're going to, let's see, we're going to maybe a tumor, maybe an aneurysm, maybe a hematoma, maybe something just that basic that it was probably on a scan and seen, something like that, a little bit less traumatic than when you think of a craniectomy. Think of trauma. Think your brain's bleeding, it's real mad, you probably have had a stroke, something along those lines. It's a little more high stress. So if we go back to medical terminology, you have ectomy, which I like to think of as removing, right? We're going to remove it. We're going to incise, we're going to cut into it, and we're going to take away. So I'm going to take it away. If I think of otomy, so I'm going to incise into it, but then I'm going to put that flap back. So I'm just basically kind of like making a hole. So I'm making an incision, looking around, fixing what needs to do, and I'm just going to put everything back like it belongs. So otomy, incise into, ectomy, we're going to take it out. We're going to take that bone flap, we're going to take it out, we're not going to put it back at the same time. So let's think about from our standpoint. So you see your case, you get called in for it, whatever's the case. There are two distinctive parts. There's really three parts of surgery: pre-op, intra-op, and post-op. But for this, I really want to focus on the pre-op and during. So when you think about pre-op, we're gathering our supplies, right? It's the calm before the storm a little bit, and we need to quick grab. So the first thing that I always grab is typically each hospital has what I like to call a cranie cart, kind of like a crash cart, but for brain trauma or brain cases. So in this case, there should be, the first thing I like to look for are your positioning aids. The patient has to get into the room and has to have their head on something, and we have to get access to it. So we're not just going to use a regular patient bed. There's two that I really like to focus on. Cleverly named, the horseshoe looks exactly like a horseshoe. It's like cushy and it's got a gel on it. The other one being the Mayfield headrest. And this Mayfield headrest, as you can see, kind of looks like a claw on one side and then a post on the other. And what happens is you have three Mayfield pens that go into this area and suspend the head, whether it's looking down like this, just depending on where we're working on in the brain, depends on which one you have. A lot of like pediatric cases per se, they like that horseshoe because the head can easily be placed in there and kind of manipulated. This, like I said, should be on the cranie cart. So you don't know what the surgeon's gonna want. When in doubt, it's better to have too much than not enough, because the time is not on your side in these. You don't have a lot of time to go running around and trying to figure out where everything is. So if you don't know, if it's not on the card, if it's not mentioned, grab them both. As they're positioning, your circulator and anesthesia can figure out which one that they need, and the surgeon and the PA and the resident and whoever it may be will come in and help position. Another thing that you also want to make note of is making sure that you have your surgical prep. So in these cases, it's not as simple as using your normal preps like you would for a laparoscopic case. You're probably going to use DuraPrep or betadine, or you're going to have to, shave the head. All of these things go into consideration, which will be communicated before the patient gets back there. But it's just nice to note, hey, do I have a shaver? Do I have a bag for that hair to go in? Because that's technically patient property. All of these things should be in that Cranie cart. As the patient is getting ready, you also have to think, okay, where's my instrument sets? So again, we have two different cases, a craniotomy, which means we're putting the flat back, and a craniectomy means we're not putting the flat back right away. Either one of those, you have to start with the basic. I have to have a Cranie set. So this craniotomy or craniectomy set, a lot of times, like the facility that I worked at, it was just a Cranie set. You always need to open that, and open it fast. Get your back table open. Time is of the essence. You are in probably a trauma case, and so you are flying. So get your back table out, get this set open. Because if you think about it, if we're going to put the flat back, that's okay. I don't need that screw set until a little bit later on. So if it doesn't get opened right away, that's okay. Have it in the window and make sure. I always have that set in the window, because even if it's posted as an ectomy, maybe they get in there and they decide they're going to put the flat back, then it's already in the window and nobody has to go running for it. With your Cranie set, they're pretty universal across the board of what's in there. You're going to have knife blades, you're going to have hemostats, you're going to have periosteal elevators, because if you think about it, again, all surgery is basic common sense. So I have a patient that is now prepped and ready and draped, and what are we going to do? I need to make sure I have Yankhauer suction up there, because guess what? I don't know if any of you have ever cut your head before, but it bleeds, and it bleeds a lot. So Yankhauer suction, I want big suction to begin with. I also need, my knife blades. I need them up there. So if I think about it and I'm like, oh goodness, I just have to get in, think about what you want on your Mayo stand strategically put. So I'm always going to put my, they got to get in. So I'm going to have my knife handles loaded with my blades. I'm going to have periosteal elevators, specifically the Langenbeck and the number 4. It's really important. Those are the surgeon's best friends, especially in the beginning. So when we go in here, I want to make sure, okay, so patient's getting prepped and everywhere to go. I can get in because I have my scalpels up. I have suction, so we're going to be able to see, okay, well, now what? Rainy clips, these blue clips. So what they do is they hold the skin and they put a lot of pressure on it, and it stops bleeding, because you have to think about it. If your scalp's bleeding and those skin edges are bleeding, well, I can't see anything. So surgeons like to use that, and it basically like pinches. It's like putting a chip clip on a bag. That's how I remember it. And they come preloaded into guns. And if they fall out of the gun, it's okay. You just take a hemostat and you pop it back on. So once they get down with that, I'm going to come off of, okay, we got in, now we can't see. How do I get through that skull? How do I do it? So what the surgeon's going to ask for is he's going to make burr holes. And you're going to see these are the, looks like drill bits with the gold back. So this will get loaded, and it will only drill so far into the brain. It's got a fail safe so that you don't just drill through the brain. And so they will make typically 3, sometimes 4, depending on the size of the flap, and they'll make little holes. And then I use what they say, kind of like connect the dots. So as they're connecting the dots, they're going to use this craniotome, and they're going to connect the dots with this. And what it is it's got, again, a guard on the back side of it, so you can't go too deep. And it's got a really fine blade in there, and it's going to cut your flap. What I like to do is stop at this point. Think about it. That flap is precious. It is the winning lottery ticket of the OR in this case in point. You don't want to drop it, lose it, or damage it. So the minute that that's off, it needs to be clearly communicated where it is and what we're doing with it. If it's a craniotomy, remember we're going to put it back. So I need to have a precious holding spot for that. So what I like to do is I like to take a wet lap. And remember, our liquids are going to be saline. We do not have sterile water on the field, only because you do not want to put sterile water in the brain. It's not good. It's not an isotope with the brain. So please, please, please don't do that. I keep saline. If I have water, I have it in a separate basin, and I'll show you in lab how to do that. So I have a damp lap with saline, and I will take that flap and put it in there because I don't want it to get dry and gross. I take it off of my surgical Mayo stand or my surgical patient. So I want it off. I want it on my back table because it is safe. So I'm going to put it back on my back table, clearly communicated where it is. Don't put it near edges. Don't do anything, because think about it. If that patient's skull gets dropped on the floor, what are we going to do? We can't grow more skull. That's not going to happen. So now the patient, we have to make an alternate route for a patient that came in and was going to have their skull replaced. Even if it is a craniectomy, you still have to communicate what you're doing with that flap. Sometimes they'll implant it back in the patient's abdomen so that it has a blood supply. Sometimes it goes to and gets frozen because that's patient property that is going to be replaced at some point. That plan, you need to ask your surgeon when it is a proper time. Don't do it in the middle of chaos of, can I pass off the flap? What do you want me to do with it? Until that point, again, damp lap, put it on your back table in a safe little nest. While that's going, so now we have the brain exposed. It's going to have a little blanket over it. That is the dura. To get the dura, we're going to use that number 4 periosteal elevator. It is like the Indiana Jones golden standard of elevators. It is blunt enough to not cause trauma, to scrape that dura and kind of loosen it up. It can also squish down on the brain just a little bit, but it is the universal tool of the OR for these cases. Neurosurgeons love it. It lives on my Mayo stand. When in doubt, it's one of the first things I put up with my suction scissors and blade. So they're going to pull back the dura because, again, we have to expose the brain. So once they pull back the dura, I always kept a nylon, or each surgeon preference, because they will sometimes put a stitch in that really quick and pull it back because they don't want to tear it. If you have a dural tear, just like if you're doing a spine surgery, you can have spinal fluid leak, and you can have pressure leak in your brain, and it causes really bad headaches. It can cause a lot of medical problems that that patient did not walk in with. So we're very careful with the dura. So now that the brain's exposed, it is super duper important to remember that you need to change out your suction. So in the beginning, we talked about the Yankauer, and now we're going to talk about the Frasers. Frasers, just like an ENT, are your best friend. So you want to make sure to exchange out your suction tips to those Frasers. You cannot use a Yankauer on the brain. That is a lot of suction, and you're going to suck out part of the brain. And we did not come here to take, 4th grade memories from this patient. So make sure you change out your suction. Sometimes, if you're worried about not being able to get the tip to exchange, I will open extra suction tubing, and I will have the Yankauer on one, and then I will have 2 suction that have the 2 different Fraser tips on it. This allows, because a lot of times the surgeon's never working alone in this. They either have another surgeon, a PA, a resident, whatever it is, and they both have access to suction, because in these moments when we haven't controlled the bleeding yet, there's not a lot of noise and talking outside of what do I need. They're very focused. It is a high-risk case, and so in those high-risk cases come a lot of high emotion, but a lot of silence. Y'all, this is not the time for what you have for lunch. Will you take my call? You need to focus Don't talk too much during this case unless you're talked to. And for me, when I was doing trauma, we didn't really communicate outside of what is needed in the case until after we have controlled the reason why we're there, whether it's a tumor, a bleed, whatever it could be. Once that was dealt with, then you can almost breathe again, and that high risk feeling you can breathe again and talk if that surgeon likes talking. It is imperative that when you're in these cases, you are cleaning the tips of your instruments. And I'm not talking about cleaning them in water, and I know that we're taught that it causes spotting. In this case, because you're in the brain, what I want you to do is always have a damp Raytec. So when we take that flap off, sometimes there's like some sharp edges, and you will use Kerosens, which are basically really dainty bone rongers. And they bite, they look like a little gun, but because the space is so little that you're in, if you're not cleaning that every time and getting that bone out, the surgeon can't see. Visualization is vital in every surgery, but especially with the brain. I'm not going to bite around what I can't see. So that damp lap will really grab that bone really well. Same thing with all your forceps, your suction tips, as much as you can. Make sure those tips are clean because that allows the surgeon to see better. It's not as sticky, it's not as tacky, it won't inadvertently stick to the brain. Make sure you're staying organized. It is chaos everywhere else. Your Mayo stand is not allowed to be chaos. We are here to be ducks on the water. You want to panic on the inside. That's okay. We've all been there. But you need to know where everything is because it's a high-risk case and sometimes it can go a little south. And if your Mayo stand is a hot mess express, we can't help anybody and the surgeon can't help, and it's not a good setup. Always make sure that your cottonoids are up and ready and have multiple sizes. They come in a whole plethora of sizes, and it is surgeon preference of what it is. Just know where they are, have plenty of them. They should always be damp. Just take some saline and squirt it on there with an asepto because you do never hand a dry cottonoid because it will stick to the brain and could cause severe damage. When you're in these cases, you also want to make sure that you have a backup plan. Don't ever just have one of anything, especially if they use it. So if you think about it, even when we build our Cranie sets, we don't just have one hemostat, and that's not just because, counting odd numbers is weird. It's because you're always going to need more than one on those vital pieces. So if you have, say, when you're making your burr holes, your craniotome, for example, always have a backup because when in doubt, that power may fail you. And if you already have it in the room, that is less time that the patient is waiting, which means that's more time we have exposure to the brain to limit the damage that their event could do. So just keep that in mind. If we can be proactive at every step, we are highly efficient. It allows the surgeon to breathe a little bit because they know that you've got this. And that's what we're going to train you to do in lab. We're going to make sure that you know the steps. We're going to make sure you know the instruments. We're going to make sure that you succeed. For the patient, we're all here as patient safety advocates because the needs of the patient come first. So we need to be efficient to that. It is also important as this case goes, you count at every step. We are not cutting corners, y'all. You have to count at every step. I've had a cranie that's had over 200 cottonoids and it is 3 o'clock in the morning. Count. And when you've got a set of 10 that is used, get them off your field. Toss them into that sponge bucket or whatever system you have lined up with your circulator. Get them off your field so that she can count them as well and she can put them visually, but they're off your field so you don't have to worry about a miscount. In the event that you have a miscount, you need to clearly communicate that. Count 2-3 times, whatever it is, you need to let that surgeon know, hey, I'm missing a cottonoid. Can you look on the field? I can't see it. Hey, I'm missing a Raytec. I had a surgeon that literally went to scrub out because it was 2 surgeons and 2 residents, and he had a bad habit of holding a Raytec in his glove. And it took us forever to find that Raytec, but it was clearly communicated so that we knew at what step this sponge had gone missing. Counts are vital. What's really important with this, and what I want to drive home before we get to lab, is now that we understand the difference between a craniotomy and a craniectomy, it doesn't matter when you get that call that it is basic knowledge. We have to get in, we have to get it, we have to be efficient. So just remember, all surgery, neuro, trauma, cysto, you name it, it all starts with common sense. We need to get exposure. We always need to visualize. We need to stay sterile. We need to know where our things are, stop the bleeding, fix the patient, send them off to be better. And it is an amazing feeling when you know that you can be highly efficient because you know this, you got this. That's what we have to do in lab. But it's important to know the steps and the differences.